And now let's get to obstructive and restrictive diseases. So over here, we're going to have restrictive diseases. And here we're going to have obstructive diseases. Okay, and first of all, are you able to tell me normal numbers in case of, let's say, volume, the tidal volume, and how many times per minute you breathe, how many breaths per minute? So what is the normal volume? And on what this is dependent, first of all? What do you think?
Around 500 ml.
Exactly. So it's around 500 mLs. Very good. And this depends on what? And remember, you got many tables, like tables which are able to predict what should be your vital capacity, etc., etc. And this is very much dependent on two main parameters. And it's not about, let's say, gender, but it's a lot about how high you are, about the height. So a tall woman is going to have a higher volumes than a small man, okay? And also age, okay? As you're getting older, of course, the volume is going to decrease, okay? But let's say in average you have half liter, very good. And what would be the normal frequency about? How many times per minute?
16 to 20 breaths per minute, I think.
Well, maybe 20 is too much, depends. Well, let's put like 15, like in average. I would say like 12 till 16. Yeah, well, or it's about those 15, yeah? So, and that's per minute, okay, in 1 minute. So this is a normal volume for 1 minute. If you're not doing anything, if you're just sitting around, and breathing and you are calm. So it's 500 times 15, okay? And now I want you to think a bit, okay? And if you're able to tell me how this pattern changes in case you're having a restrictive or obstructive disease, okay? And of course, you're going to tell me about obstructive, that there's air trapping and these things, but I don't want you to think about this now. I want you to rather think about only the volume and the frequency. And it's very intuitive in a way, so it's easy to figure it out, especially in terms of restrictive disease. So how do you think this would change this pattern?
In restrictive, the frequency would increase.
Very good. And why?
Because in restrictive disease, you have difficulty fully expanding your lungs.
Very good. So basically the volume decreases. So you look on restrictive diseases, although the restriction could be whatever. It could be, and we're going to talk about it could be intrapulmonary or extrapulmonary, okay? Doesn't matter. But in both cases, the volume is going to be decreased. It's harder for you to expand the lungs, okay? So you're going to decrease it, the volume. And because per 1 minute, you still want to get the same amount, because your tissues want the same amount, you're going to compensate it by increased frequency, yeah? So the frequency is going to go up. If we look on the other side, if you look to the obstructive diseases, then it's different over here, because the problem is not in the elasticity of lungs or the chest. Lungs expand normally, it's fine. But the problem is obstruction, because you have a thinner pipes, The pipes with which you breathe are not as wide. And it's always easier for you to breathe slower through small pipes, because you won't cause any turbulence and whatever. So basically, if you want to save power and everything, you're going to breathe slower. But because the elasticity is fine, you can expand the lungs more in a way. Okay, so that's why rather in obstructive disease, the volume is going to be increased, but the frequency is going to be rather decreased. And again, you want to sort of match the 500 milliliters times 15 per 1 minute as a result, okay? So over here, it's going to be higher. It's going to be 600, and you're going to breathe 12 times per minute, yeah? Okay? And this is a very simple and general view, simplified view on differences in breath patterns between obstructive and restrictive. Of course, in obstructive, you really have air trapping, but we're going to talk about that in a minute, okay? Yeah? And now let's get to obstructive. So tell me some examples of obstructive diseases.
Asthma and COPD.
Very good. So first of all, it's going to be asthma. And why are we putting asthma aside compared to COPD? Why? Because both are obstructions. But the important thing that you should really remember from today is that in case of asthma, it's an acute obstruction, and asthma is a disease which has its like bursts, okay? So why I'm telling this? Well, because the obstruction happens only in different times, okay? And it's exacerbated by some infection or whatever, some allergens and etc., etc. But if the patient is doing well on drugs, then you won't see any obstruction, okay? So it comes in attacks. They're asthmatic attacks. And especially if the person is young and at the beginning, like has asthma for a few months or years, not too many years, because afterwards, if it's for many, many years, of course, there's going to be some, let's say, consequence out of it. But if you imagine a young person with asthmatic attacks, then you know that he has problems only during these outbreaks of asthma. But if he's well compensated on drugs, he's going to do very fine and there will be no obstruction. So also on spirometry, you won't see any obstructive curves. It should be fine, okay? The spirometry should be very similar to a healthy person, okay? In contrast to this, in COPD, which means if we use the first letters, C means chronic, okay? So chronic obstructive pulmonary diseases. And chronicity in this time means it stays there. It's a chronic obstruction, and basically you won't improve it with drugs. There is a constant bronchoconstriction, okay? Yeah? So that's why basically if someone has a COPD, if you measure this person anytime, there's going to be some obstructive curve that you're going to see on spirometry, okay? So that's crucial. COPD is a group of diseases. So which ones you would mention over there? What do you think?
Emphysema.
Very good, very good. And this students mix sometimes, but you are very right. Please remember emphysema is a chronic obstructive disease. And is there one that we talk about even more than emphysema?
I'm not sure, maybe bronchitis.
It is chronic bronchitis. Very good. So it's chronic bronchitis. So first we should talk about chronic bronchitis, okay? So chronic bronchitis as one of them. So chronic bronchitis. And what would you imagine if someone has chronic bronchitis, how the person looks like, and how is the chronic bronchitis defined? It's very special definition. Tell me.
There's an increased thickness of the mucosal glands, I think.
Fantastic. And there's going to be also production of the sputum. It's going to be pretty big, so they're going to have lots of sputum, but not extreme amounts. But definitely they're going to have lots of sputum. Not extreme, I'll tell you in what case there is extreme production of sputum. But over here they have a serious production of sputum. And how do they look like? They cough. They cough all the time in the morning. Okay, in the morning they wake up. And who would you imagine? What is their addiction typically?
Smoking.
Smoking, very good. So, first of all, you should imagine smokers. And the definition of chronic bronchitis is special, where you should imagine a productive cough which continues for 3 months in first year and then in 1 year again for 3 months at least. Okay. Of course, you have to rule out other causes of cough, like, for example, heart failure. So if you rule out everything and the person is coughing continuously 3 months in a row, 1 year, and then 3 months in a row the next year without any other obvious causes, possible causes of the cough, then you can say he has chronic bronchitis. So he has some sputum, he coughs in the morning, or during the day. So chronic coughing plus a sputum production, that's very likely. And he's smoking, so that's very likely chronic bronchitis, okay? And there is something else what you should imagine. What's the problem? Well, they have an obstructive disease. So, but the vessels that are coming to the lungs are pretty fine. The capillary bed is, there's lots of it. So typically they have a ventilation perfusion mismatch. Okay, they're ventilating less and perfusion is still kept. So in this case, this means they are hypoxemic and they are producing lots of erythropoietin. So they have an increased erythrocytes, okay? And this is the reason why we also see plethoric face. You call it plethoric face. They have a red face and neck, okay? That's very plethora, that means you have lots of erythrocyte. So they have a plethoric face, okay? And now it depends how much they are hypoxic, okay? How serious is the hypoxia they have? And if it's serious and they have lots of erythrocyte, but the erythrocytes won't be occupied by, the hemoglobin in the erythrocytes won't be occupied by oxygen, then the hemoglobin will look blue, cyanotic. So remember, first of all, they have a plethoric face. It's like red face, okay? But if it's even more serious, then they're going to be blue. And they're typically, that's why you call them blue bloaters, okay? So they're blue. And you know what? Remember, they are rather obese also. So you should imagine someone who is obese, sometimes has plethoric face, sometimes it's like purple, because they're like decompensated in this case. So in more serious cases, you see really blue bloaters. They're blue and obese. Funny thing is their dyspnea is not so serious, okay? So dyspnea is, but it's not so much. They are not so dyspneic. They are sort of feeling fine, but they're not looking fine too much, okay? So these are blue bloaters. And please don't take this like 100%, okay? Because always you have some kind of, let's say, emphysematic to bronchitic spectrum of diseases, okay? It's rather bronchitis or rather emphysema, but if it's rather bronchitis, then they're going to rather look like this, okay? Well, and of course, naturally now, and I'm going to put like chronic bronchitis in a box. And the second one, which belongs over here, it's the emphysema, as you said. And what's the problem of emphysema? Well, first of all, these guys rather look thin. And you call them pink puffers, okay? So these guys are rather pink puffers. And puffers means that they are sort of trying to keep the air inside by their mouth. They are closing their mouth. That's why they're puffing. And the reason is that they don't want their airways to collapse. So they're sort of doing if we use a machine ventilator, we call it PEEP. So this is an artificial positive airway pressure. They're keeping their pressure they're not getting rid of all the air because they don't want their airwaves to collapse, okay? So you call them pink puffers. And emphysema means what? Where do you see it? Well, it means typically that you are losing septa in the alveoli, and important thing is also you have an obstruction in the terminal bronchioli. Okay, so basically to remember its obstruction, if this is a alveolus, okay, so typically your septa are destroyed, so you are losing surface for the exchange of the so it's going to look like this. So you lost surface for the exchange of O2 and CO2, and also here are some ligaments which are holding the terminal bronchiole, and these are like sort of not as elastic. They are like they wear off. So that's why this collapses over here. And look at the obstruction you're having over here. Okay, so this is obstruction for the exchange. Okay, so that's why also there is air trapping inside the alveoli. Okay, so in terms of emphysema, which is also due to smoking, and smokers have it, so either they have chronic bronchitis or they have emphysema, and in both cases there's going to be obstruction. That's why you put it under COPD. Okay, but in emphysema, first of all, they are rather pink. They are thin, not obese, but they are like low weight. They look sort of cachectic. Remember that, cachectic. And one more thing, what is very typical, and you can find it on CT or X-ray, is that their chest, if you do it, this is a sort of a chest of a normal person. Okay, let's do it. It's a cross-section of a chest of a normal person. Okay, and what you will see in emphysema is they have a barrel chest. Okay, yeah, that's typical with emphysema, so barrel chest. So, but both are obstructive diseases, and still with emphysema, please. So either it can be acquired by smoking, but unfortunately there is one problem that you can have, and you can have emphysema typically when you're 30 or 40. So normally people with emphysema without any predisposition, they're going to have it later, like 50, 60 years. In case someone comes to you and has an emphysema and he's like 30 or 40 years old, think of one thing especially, and what is that? That's deficiency of alpha-1 antitrypsin. These guys, they're young and they have emphysema in very young age, and this is very typical, so please think of it. And also what you should think of concerning deficiency of alpha-1 antitrypsin is not only lungs, but also liver. Because people typically will have, it depends on the seriousness of the disease and how decreased the levels of alpha-1 antitrypsin are. But these people have liver cirrhosis. And would you know what is the connection between the emphysema and cirrhosis? Well, it's a very beautiful connection, because actually alpha-1 antitrypsin is supposed to block all the elastases and whatever in the body. And typically when you have an inflammation, for example in lungs where you have neutrophils and they release elastases, you need them to sort of fight the disease and whatever. But if there's much of it, then it turns against you and it destroys your lung. And this is what happens when you have alpha-1 antitrypsin deficiency, because alpha-1 antitrypsin blocks the effect of these elastases and sort of keeps the reaction locally. Okay? Well, and why you have the decreased levels? Well, it's inherited. You have a mutation. You have mutated alpha-1 antitrypsin, and this protein is misfolded. And actually, it's not released from the hepatocytes, so it stays in the hepatocytes. So that's why you're going to have, depends how serious it is, you can have it really early in the age, and you can have a liver failure when you're a child. So this is also one of the most common causes of liver transplantation in children, the deficiency of alpha-1 antitrypsin, because it's misfolded. It stays in the hepatocytes and destroys the liver in this way. And because you have decreased levels in the blood of alpha-1 antitrypsin, this also, let's say, leaves the elastases unblocked, so they will destroy your lungs. So this is the beautiful connection between emphysema and cirrhosis in these patients. And basically why I'm telling you this is it's sort of very important, and you should think of it and do DNA tests even earlier, because you can help the patients with the lung diseases, because you can give alpha-1 antitrypsin. Okay, so you can sort of prolong the life of their lungs, not the liver, but you can really help the lungs. Okay, otherwise, in both cases, if it gets really serious, the patients end with lung transplantation as well as with liver transplantation. Okay, so remember, a young person with emphysema, check for alpha-1 antitrypsin levels, and they could be decreased. Okay, and when you find this, please do a DNA testing, because it runs in the family, so you can really help someone young in the family. And also immediately treat the patient with alpha-1 antitrypsin, because you can really slow down the processes in the lungs. So alpha-1 deficiency, it's not as common, but watch out. In some countries, like in Scandinavia or Baltic countries or Portugal, it's more common. So think of that. Okay. Anyways, emphysema, this was the second entity which you put in one big clinical group, which is called COPD, chronic obstructive pulmonary disease. So, and why we put these two together, the chronic bronchitis and emphysema? Well, you can have sort of almost pure bronchitis or almost pure emphysema. That's possible, but totally in most of the cases, they come together. So if you're having bronchitis, you should expect that in some parts of the lungs there's going to be emphysema. And this is mainly because of smoking, because that's the most common cause of both of them. Chronic bronchitis is a bit more common, okay, but the smoking is the major problem. And that's why clinically you put these two together in one big group, which is called COPD, okay? And now we're coming to the last disease, last out of these obstructive lung diseases, and that is bronchiectasis. I'm going to write it down. Bronchiectasis. And bronchiectasis are in one thing similar to emphysema, but that's it. And that means dilation. Ectasis means dilation. Emphysema, this is about dilation of the distal parts of this happens in alveoli and respiratory bronchioles. Okay, there's a destruction and dilation of the system. In contrast to this, in bronchiectasis, there's a dilation in medium and small sized bronchi. And the way you should look on bronchiectasis is rather that it's not a primary disease, but it's a secondary disease to infections that are located in these particular parts of the lungs. And that is also why you have two types. You have only local bronchiectasis located in one part of the lung. Typically, this is after some serious pneumonia, for example, in childhood, and this develops over there in this particular part. Or you have diffuse bronchiectasis, and this is what you see in patients that have recurrent lung infections. And what's the problem? Well, the problem is systemic. There is some genetic disease, and they have problems with getting rid of the infections from the airways. And among these genetic diseases, please, first of all, you should think of is cystic fibrosis. That's the first one, cystic fibrosis. Then you can think of, for example, primary ciliary dyskinesia, or you can think of any kind of immunodeficiency, like, for example, IgA or IgG immunodeficiency. And why this is important? Well, because the patient can have cystic fibrosis, but no one knows about it because no one thought about that he could have some kind of light cystic fibrosis, okay? And now you figure out that this patient has diffuse bronchiectasis. Well, then you should test the patient for cystic fibrosis, okay? And this works also the other way. So in case a patient with cystic fibrosis comes, then you should think of diffuse bronchiectasis. And if we talk in general about bronchiectasis, what is the hallmark? Well, the hallmark is sputum. They have a productive cough and huge amounts of sputum that they produce. Okay, they can fill up 1 cup of sputum very easily. Okay, so they cough. It's a purulent, productive cough, and the amount of sputum is enormous. It's much bigger than, for example, in chronic bronchitis, they produce just a bit of sputum. Okay, over here it's enormous production, and the sputum is yellow or greenish. Okay, and sometimes they can have a complication. They can even have a hemoptysis. Okay, so remember, patients with huge sputum productions, that could be bronchiectasis. Another hallmark of bronchiectasis is infection by gram-negatives, and especially Pseudomonas. Okay, so I'm going to write Pseudomonas. And this is very typical. Infection by Pseudomonas is, again, it tells you, wait, watch out, it could be bronchiectasis. And the thing, what you typically do, you have these patients, they have recurrent infections, lung infections all the time. And really, basically, you should imagine someone that's getting antibiotics all the time. And there could be just a slight indication for pneumonia, and immediately you give them antibiotics. And in some severe cases, they get antibiotics preventively through the whole year. Okay. And what they do with these antibiotics, they rotate them. Okay. And not to, let's say, create a resistancy. Okay, so that's why they rotate the antibiotics all the time. So the patients with bronchiectasis, they have repetitive infections, lung infections, and they get different kinds of antibiotics all the time. The doctors, they rotate them. Okay, so those are the main hallmarks of bronchiectasis. Remember, productive cough, lots of sputum, and remember, if we should mention one bacteria, please remember Pseudomonas. Okay. Well, and to sum it up, so I gave you 4 examples of obstructive lung diseases. First of them is asthma, which is a reversible obstruction. And the other 3 are irreversible. And 2 of them are sort of in one group, which is called COPD, that's chronic bronchitis and emphysema, because they come together all the time, and the major cause is smoking. And the last example, the 4th one, are bronchiectasis, which are created rather secondarily to some serious lung infections. Okay, and they could be local or diffuse. And the diffuse ones are connected with some genetic diseases, like cystic fibrosis, for example. Okay, so that was all about obstructive diseases, and now let's get to restrictive ones. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.